Hello, my name's Anthony Krimmel, and I'm doing my pathology project on pulmonary valve stenosis. So to begin, I'm just going to go over some like a basic anatomy physiology of the pulmonary valve. So the pulmonary valve is a semilunar valve, which means that it's in the shape of kind of like a half crescent moon. It's in the lower right chamber of the heart. It's located between the right ventricle and the pulmonary artery, and its function is to open up when the right ventricle contracts to push the blood, deoxygenated blood in the right ventricle into the lungs to get oxygenated, and then close to prevent the backflow of blood into the right ventricle. Okay, and then so what exactly is pulmonary valve stenosis? So is basically when the cusp that make up the pulmonary valve or the leaflets, they become thickened or partially fused, and the opening to let the blood through the right ventricle essentially becomes restricted. And then there's the side effects such as more pressure is created in the right ventricle to push an adequate amount of blood through to the lungs through the pulmonary artery, and and then this could cause effects such as right ventricular hypertrophy, which means the right ventricle has the muscle gets stronger and bigger, and then it takes more energy for the heart to push the blood into the lungs. And the right ventricle is typically smaller than the left ventricle because the left ventricle needs to pump blood out to the rest of the body, whereas the right ventricle needs to pump blood just to the lungs. So when the right ventricle has hypertrophy, it creates serious problems because the typical physiology of the heart doesn't function so that the right side is as strong and as big as the left side, and this could create a lot of problems and be possibly fatal. So so if someone has pulmonary valve stenosis and it is untreated and let's say it's moderate but it gets gradually worse, then the heart will slowly work more and more, then the hypertrophy will occur. And so individuals that have mild to moderate, or should I say babies, this is typically a congenital heart defect malformation. If it's mild to moderate, you won't see any symptoms. It won't be noticeable. And then these are like a mild to moderate pulmonic valve stenosis. It's going to be 30 to 60 milligrams of mercury. And then the severe pulmonic valve stenosis is going to be 60 to 90 milligrams mercury. And this is where you're going to see very noticeable symptoms, and you'll be able to realize, and the doctors will immediately look into it based off the symptoms created by that, which we'll get into. So how prevalent is this? So congenital cardiac malformations are pretty common compared to a lot of other pathologies. About roughly 5 out of 1,000 infants are born with a congenital cardiac malformation. And then roughly 8 to 12%, so cut the middle, say about 1 out of 10 of these infants born with these congenital cardiac malformations are born with a stenotic pulmonary valve. So like I said, 95% of these cases are congenital, and then the remaining 5% could develop in adulthood, and this is normally as a result of some other cardiovascular disease or something that would cause a malformation in the valve. And then this is much more rare, and you don't see it as much. Or it could be the case where the valve starts out very mildly stenotic, and as they age, based on lifestyle or whatnot, the valve could become more stenotic as the individual age, to the point where it's now becoming an issue. But generally, you see these cases in infants. So the symptoms I was talking about that you'll notice right away is that neonates with really severe congenital pulmonary valve stenosis, you're going to immediately notice that they have cyanosis, and it's mainly, you'll see it in their face, very prevalent. It could go everywhere, but mainly in the face and around the lips. Um, and then, as stated, if it's a mild to moderate, it would normally take a little while for it to get noticed, and also, and it's normally noticed by a heart murmur. And then, as the valve becomes more stenotic, the heart murmur will become more prevalent. And then that's when they'll start looking into more. But let's say it's very mild at first, it could be years before they even realize that they have a stenotic valve, because typically infants and small children will not be showing any symptoms, be active, act like everything's okay. Now, let's say if you were born with a mild pulmonary stenotic valve, and you age, and let's say it becomes worse based on like lifestyle, or just this stenosis just increases, so the aperture in the valve becomes smaller, and then the heart starts having to work harder on the right ventricle. You'll notice symptoms in like teen to even older adults, where you're going to have just lack of energy. You're going to, anytime you push yourself, you're going to quickly fatigue. You might experience lightheadedness, struggle breathing, and right ventricular angina, which is pretty much going to manifest itself as right-sided chest pain. And which makes sense that these would be the symptoms, because your body is struggling to get the blood oxygenated. So you're going to get symptoms of when you're lacking oxygen, such as lightheadedness, trouble breathing, and tiredness. So let's go over the prognosis and treatment. And so with this pathology, pulmonary valve stenosis, survival is very common. You don't see too many individuals like dying from this immediately, because if it's mild or moderate, you could still live your life and it's not going to have too much of an effect. And when it does become very like severe, the symptoms become very prevalent. The individual knows something wrong, that's going to get checked, it's going to get diagnosed relatively quickly. And it's, heart failure is a very big possibility. So then treatment normally occurs right away. And then the treatment, beginning in 1982, is a very non-invasive procedure. It's called balloon pulmonary valvuloplasty, and there's a very low mortality rate. It's a great procedure, because this is where you go into the heart without having to crack the sternum and go through open heart surgery, which carries a lot more risk, a lot longer recovery. And that you pretty much, what happens is they take a catheter, usually through the femoral artery. They'll bring it all the way up into the ventricle, and then they will put a balloon into the valve and essentially open the balloon till the aperture in the valve starts to widen. And it's very safe, because the mortality rate roughly 0.24%. I saw different rates, and this is about the average what I saw, but it's rare. When it comes to heart procedures, it is definitely on the safer side. Now, there is one drawback to this, is that about half the individuals experience pulmonic regurgitation. And as you can see on the picture here, when they're doing this procedure, they're opening it up. But now that, of course, the physiology, it doesn't necessarily fix this physiology of the valve all the way. It will open it up. But now, instead of it having trouble opening, now it could have trouble closing. So now we're going to see some blood backflow, and that's called regurgitation, is backflow through valves. And typically if regurgitation does happen, like I said, it's about half patients, it is incredibly mild. And then the individual who had this procedure done is going to feel so much better. Their life will get better. The ventricle will start to decrease in size if it has increased. The pressure and everything is good. And this is for the next, maybe years to tens of years. But the regurgitation can possibly get worse. But then at that time, at least the heart was saved and it's getting back to normal. And then intervention could once again be done to treat the regurgitation. So what are the imaging modalities? Because that's what we're interested in here, because it's our T program. And so the gold standard for pretty much most exams of the heart is a lot of that. Well, anything to do with the valve, should I say, is the echocardiogram, because it is great at showing the anatomy of the valve. It's able to localize the stenosis, see where the problem is. It's able to look at the shape of the valve, if anything's different, how the valve's functioning. And most importantly, it's able to give you a good look at the pattern of blood flow. Is there regurgitation happening? Is it struggling to go through the valve? And the echocardiogram is normally what gives the definitive diagnosis for pulmonary stenosis when it is suspected. And then also other imaging modalities, we have ultrasound through the continuous wave Doppler. And this one's very useful because it is able to measure peak systolic velocities and provide estimates of the pressure gradient inside the ventricle and everything. And then this is huge because when you have a stenotic valve, you're going to have a higher gradient pressure inside the ventricle, and that's a clear indicator that the valve would be stenotic or that there's something wrong going on, if something's off. And also, if you want to see, let's say, the extent, let's say they found out this patient's stenotic, his pulmonary valve stenotic or her pulmonary valve stenotic, and it's gone untreated, and they want to see how much hypertrophy is going. Chest x-rays are actually really great at showing the extent of how much hypertrophy has occurred on the right side of the heart, atrium and ventricle. So all three of those are very useful. And then lastly, I just want to talk about why I was very interested and curious in doing this as my project. Because I was born with a severe pulmonary valve stenosis, and I had the balloon pulmonic valvuloplasty when I was 2 weeks old. Obviously, I have no recollection of any of this. My childhood was completely normal. I was very active, and I always played sports my whole life. That was my passion. Doctors told my mom I might not be able to, participate in sports and everything, but I was very active. I played, and I was pretty good, and it was my passion. And I do remember that towards the end of high school, and it's my senior year, and I'm playing all these sports, and so it was a time of my life. And I remember being extremely fatigued. Very quickly, I could tell something was up. I knew I had this heart condition, but it's been a while since I went in. And then they noticed that my heart was regurgitating, the valve was regurgitating, and my heart was expanding. But it was still, they said, safe. We did tests. I was able to continue to finish the sports that year after months of testing. And then until it did progressively get worse, and at 25, I had a pulmonary valve replacement with the pig valve. And since then, everything has been better. But yeah, so here's all the references I used in collecting the information on this. And I enjoyed reading about it and learning about this pathology, especially for something that's affected me so much. And yeah. I hope you found it interesting. All right.